In this video, we look at high-flow nasal cannula as an alternative strategy to provide non-invasive respiratory support. The video includes air treatment protocols, indications of use, results from studies, precautionary measures. Despite the lack of studies to support its usability, safety, and effectiveness, high-flow nasal cannula is being widely accepted by the medical community. At present, there have not been any randomized controlled studies on the use of high-flow cannula for neonates less than 28 weeks, and very little data is available from non-randomized studies. However, the air must be humidified and heated, and the flow rate should be greater than 1 liter per minute when using it. Some of the other indications for use include respiratory distress syndrome, apnea, atelectasis, pulmonary edema, weaning from nasal continuous positive airway pressure, and post-extubation respiratory care. The binasal prongs of the high-flow nasal cannula are smaller than those used for CPAP, whereas the gas flow delivery is greater than 1 liter per minute, with typical gas flows ranging from 2 to 8 liters per minute. At the start of high-flow therapy for premature neonates, choose appropriate-sized nasal prongs to ensure the right amount of leak at the nares. Care should be taken to make sure that the prongs do not block the nares. As per recommendations, the size of the nasal prong should be 50% of the diameter of the nare. In case of preterms less than 29 to 32 weeks old, a close evaluation is required as they may need lower flow rates to reach the same distending pressure as older preterm neonates. While clinical trials have not explored the use of high-flow cannula in neonates, several studies have shown that measured pressures are similar to those usually set with CPAP. In addition to this, it is shown that high-flow pressures decrease with decreasing flow and increasing infant weight. The high-flow pressure also depends on the individual patient and the amount of leak at the nares and the mouth. However, high flow rates of 2 to 8 liters per minute may create excessive positive pressure. The high-flow nasal cannula lacks a pop-off value to help relieve the excessive pressure, and it does not have any mechanism to measure the pressure in the neonate's airway. Due to lack of evidence, guidelines for clinical practice should be based on published trial protocols. Always remember that gases are to be heated and humidified at all times. Initial gas flow in the range of 5 to 8 liters per minute should be set for preterm infants. Cease high flow support from 4 liters per minute, as there is little evidence that lower flows are effective. Cease high flow support outright from higher gas flows if the infant recovers with no signs of respiratory distress. In the absence of an evidence-based weaning guideline, review the gas flow every 12 to 24 hours and wean by 1 liter per minute reductions. None of the randomized trials have used gas flow greater than 8 liters per minute, and we recommend 8 liters per minute as the maximum flow for preterm infants unless in a clinical trial setting. When using high-flow cannula to treat preterm infants, determine failure criteria clearly to expedite escalation of therapy whenever required. We recommend using objective criteria such as increasing supplemental oxygen requirement, high frequency or severity of apnea, and respiratory acidosis. In all cases, a prong sized should be chosen carefully to maintain an appropriate amount of leak at the nares. In short, we covered air treatment protocols, indications of use, results from studies, precautionary measures.